And now we are coming to the second presenter, Lisanne Pattynama. She's a research fellow and PhD candidate from Amsterdam Medical Center. She's one of the rising stars from Jacques Bergmann's group, and she will talk about preemptive VAC-Stent placement to prevent anastomotic leakage after esophagectomy.
Yes, waiting for the slides. Thank you for the kind introduction. So my name is Lisanne Pattynama. I am a research fellow at the Amsterdam University Medical Centers. And first I would like to thank the organizers of EndoSwiss for the nomination. And I would like to tell you about our plans for the Prevent Feasibility study. So during an Ivor Lewis Esophagectomy, a gastric conduit is created with an intrathoracic anastomosis. And leakage of this anastomosis is a severe complication which is associated with increased morbidity, mortality, and of course also prolonged ICU and hospital stay. And the incidence of anastomotic leakage after an Ivor Lewis esophagectomy is 10 to 15%, but even described higher in literature. At our center, since 2018, the primary treatment for these patients is endoscopic vacuum therapy using a sponge. And during the implementation phase of endoscopic vacuum therapy, we conducted a case series of patients with anastomotic leakage treated with such a vacuum sponge. And we saw a success rate of 74% with a relatively low adverse event rate. And recently, the VacStent has been introduced as a new treatment for these patients. And the VacStent is a fully covered nitinol stent with a polyurethane sponge attached to its outer surface. And for this treatment, the VacStent is endoscopically placed over the defect and attached to a vacuum pump, which then generates a negative pressure around the stent, causing closure of the defect, drainage of fluids, and stimulation of perfusion and wound healing. And additionally, the vacuum prevents the stent from dislocating, and the stent allows for oral intake and seals off the defect. So at our center, we conducted a case series with the first patients treated with the VacStent, and we included 23 patients, of whom most had an anastomotic leak after an Ivor Lewis esophagectomy. And we saw a success rate of 91% without any adverse events. So this VacStent works very well. But what if we go back and could prevent anastomotic leakage from occurring in the first place? So we hypothesize that placement of a VacStent right after an Ivor Lewis esophagectomy reduces the risk of anastomotic leakage. And during this preemptive treatment, the patient can have intake, so the enhanced recovery after surgery protocol is maintained. Furthermore, this VacStent stimulates healing of the anastomosis by eliminating contact with gastric and bowel fluids and stimulating perfusion. So with this, prevention of anastomotic leakage may be possible, and with that, also the reduction of the morbidity and mortality that goes along with it. And after 5 to 7 days, the VacStent can then be removed. So what do we know about preemptive endoscopic vacuum therapy? Miller et al. Have looked at prophylactic vacuum sponge placement after an Ivor Lewis esophagectomy in high-risk patients. So they looked at 67 patients and found a low AL rate of 7.5% without 30-day mortality. And this was in high-risk patients. They are also currently conducting a randomized controlled trial on the same topic. But as we know that with the VacStent, oral intake remains possible and the success rates are possibly higher, with this Prevent Feasibility study, we will be looking at prophylactic placement of a VacStent after Ivor Lewis surgery in 20 patients. And with these results, we can then set up a randomized controlled trial on the same topic. And with these studies, we hope to gain insight in the potential of preemptive endoscopic vacuum therapy after esophagectomy to reduce the rate of anastomotic leakage. So, in conclusion, prevention of anastomotic leakage after an esophagectomy could reduce severe morbidity, and the VacStent preemptively could reduce this risk of anastomotic leakage. Furthermore, more research is ongoing to assess the best indications and techniques for endoscopic vacuum therapy, both in a preemptive way, but also for treatment of defects. So currently we are setting up a multi-center endoscopic vacuum therapy registry or database, first in the Netherlands, and we are also going to expand internationally. Furthermore, we have recently launched our new website, which is evt-academy.com, where we share our experiences on endoscopic vacuum therapy in the upper gastrointestinal tract, including presentations, protocols, videos, and an expert panel for any questions or cases you might have. So with that, I would like to thank you for your attention, and if there is time, I would love to take questions.
Thank you. Thank you, Lisanne. I think this is a very important study for the clinical practice every day. I have one short question. Do you place the stent intraoperatively or after the surgery?
No, it's really in the operating room. Yeah, so right after the surgery.
And after how many days you remove the stent first time?
We will remove it after 5 to 7 days. It's also due to maybe when it's possible in the schedule of the endoscopy room.
Okay, thank you very much.
Thank you.